like so. And this will essentially expand the rib cage, and the rib cage will rise. This will cause the thoracic cavity volume to increase, and an increase in thoracic cavity volume will mean that the intrapulmonary volume will also increase, which will lead to a decrease in intrapulmonary pressure. A decrease in intrapulmonary pressure means that gas can flow from a higher pressure to lower pressure, so from the outside to the inside, so gas flows into the lungs. Then we have expiration. In expiration, the diaphragm will rise and the intercostal muscles will relax. And so the thoracic cavity will decrease, will shrink, and the rib cage will descend. So the thoracic cavity volume will decrease. This will cause the intrapulmonary volume to decrease, and which will cause the intrapulmonary pressure to rise, to increase. And so gas will flow out from the lungs, from a higher pressure within the lungs to a lower pressure outside of the lungs in the atmospheric pressure. Hope that all makes sense, the inspiration.
Okay, so when we inhale, because of the contraction of the diaphragm and external intercostal, the lung expands. So when we inhale, air enters to the lung expands in three ways. Vertically, because the diaphragm descends. Antero-posteriorly, ang tawag natin doon ay pump handle. And laterally, yung bucket handle. So lumalaki yung chest natin. And according to Boyle's law, as we inhale, okay, the volume increases, but the pressure decreases. The lung becomes more negative as we inhale. So air flows to the lung, but the volume increases. The pressure decreases, but the volume decreases. The volume increases, the pressure decreases. During exhalation, as the diaphragm relaxes and the lungs collapse because of the elasticity, the pressure increases and the tidal volume decreases and air gets out of the lung. So when we exhale, there is always air in our lungs remaining due to the pull of the pleural cavity. The pleural cavity is always negative, and that keeps the lungs always inflated. The pleural cavity is always negative before inhalation, during inhalation, and during exhalation, always negative. So when we exhale, there is always air in our lungs due to the pull of the pleura. And what do you call the air in our lungs after we normally exhale? Ano yung hangin na natitira sa lungs natin after we normally exhale? Anong tawag yan?
FRC.
FRC. Ayan, nalimutan nyo na. FRC. Residual volume is when you exhale all the air. Lahat ng pwedeng hangin ilabas. So, nag-exhale ka, tidal volume. Pwede ka ba mag-exhale? Yes. Ano yung hangin lumabas after the tidal volume? Anong tawag doon?
Respiratory volume.
Yes, ERV. Lahat ng pwedeng ilabas. At yung matitira, ang tawag doon, RV. Ayan. So, during spontaneous breathing, binanggit natin, the diaphragm and the other muscles create gas flow by lowering the pleura, alveolar, and airway pressure. So, according to Boyle's law, okay, as pressure decreases, the volume increases, and vice versa. So, sa positive pressure ventilation, baliktad. Nag-inflate nga yung lungs ng pasyente, but the lung becomes positive. Ano ba nangyayari when the lung becomes positive? So, during positive pressure ventilation, the pleura also becomes positive. The lung also becomes positive. And because of that, naiipit yung ating superior and inferior vena cava. Again, titingnan natin yung mga pressures natin. Yung ating peak pressure is very important. Dapat less than 35 siya. Kasi katulad makikita nyo rito, ano? Conditions that may increase your peak pressure ay yung airway resistance, decreased lung compliance. Ipo-forward ko na kasi na-discuss na naman natin halos lahat. Ano? Yung peak pressure, mean airway pressure, isa na lang, hindi natin na-discuss yung mean airway pressure. Sa statistics, ano ba ibig sabihin ng mean? Sa statistics, pag sinabi nating mean. Diba? Mean, median, mode. Yung average. Diba? So, in 1 minute, yun ang mean natin, yung average. So, peak pressure is the pressure inside the airway. Plateau pressure is the pressure inside the alveoli. May isa pang pressure, yung mean. Ano yung mean? Yun ang average pressure. Yun ang average pressure. Remember, sa positive pressure, naiipit ang ating superior and inferior vena cava. Pag naipit siya, decreased venous return, decreased cardiac output, decreased blood pressure, decreased urine output. Kaya sa mechanical ventilator, para makita natin yung effect ng positive pressure sa cardiac output, ang titingnan natin ay mean airway pressure. Eh sir, ilan ba dapat? Dapat less than 15, 1.5. 1.5. Kapag masyadong mataas ang mean airway pressure natin, naiipit yung puso. Naka-follow nyo ba ako?
Yes po, sir.
Okay, so kompleto na tayo ha. Ang peak airway pressure para sa airway dapat less than 35. Ang plateau pressure para sa alveoli dapat less than 30 to prevent barotrauma. Yung epekto ng positive pressure sa heart, yun ang mean airway pressure. Kapag ang mean airway pressure natin ay more than 15, 1.5, eh naiipit yung puso. Pag naipit yung puso, decreased cardiac output, decreased blood pressure, decreased urine output. Yun ang mga effect ng positive pressure. Kaya yun ang mga titingnan natin. Okay? So, cardiovascular consideration, mean airway pressure. Ayan. Positive pressure ventilation increases mean airway pressure and decreases cardiac output. Kaya yun ang titingnan natin, yung mean airway pressure. Okay? So, ang mean airway pressure, dalawa ang kahulugan yan. Kapag masyadong mataas ang mean airway pressure, naiipit yung puso. Correct. Pero kung mataas din ang mean airway pressure, ibig sabihin nun, naka-inflate yung lungs natin. Kaya kapag mataas ang mean airway pressure, maganda ang diffusion. Kaya ibabalance natin yon. Okay? Pag mataas ang mean airway pressure, naka-inflate yung lungs, maganda ang diffusion. Kaya lang, kung mataas ang mean airway pressure, naiipit din ang puso. Kaya dalawa ang kahulugan ng mean airway pressure. Isang good at isang bad. So ano yung mga pwedeng magpataas ng mean airway pressure? Since mean airway pressure is a function of inspiratory time, respiratory frequency, peak inspiratory pressure, and PEEP, these 4 parameters should be kept to a minimum. So, 4 ang pwedeng magpataas ng ating mean airway pressure. Inspiratory time, babalik ko ulit. Inspiratory time, respiratory frequency, number 3, peak inspiratory pressure, and lastly, naka-bold yan, PEEP. So what does it mean? So, 4 ang pwedeng magpabago ng ating mean airway pressure. Inspiratory time, back-up rate, frequency, peak pressure, saka yung PEEP. Naka-highlight yung PEEP. Ano ibig sabihin nun? Pinakamalaking factor yung PEEP. Kaya kung meron tayong PEEP, remember this, ano? Pag tayo magbibigay ng PEEP, sir, kapag merong refractory hypoxemia. Remember, maraming uri ng PEEP, ha? Nabanggitan natin siya last time. May tinatawag tayong physiologic PEEP. Yun ang normal na nasa lungs natin. Mga 3 to 5 cm. Therapeutic PEEP, more than 5. So kapag ang PEEP mo more than 5, yun ang therapeutic PEEP. Kaya lang, kapag napasobra yung PEEP mo, ay naiipit din yung ating puso pag napasobra yung PEEP. Kaya ang pipiliin nating PEEP ay yung best PEEP o yung optimum PEEP, kung saan nagbibigay siya ng magandang oxygenation na hindi masyadong compromise yung hemodynamics. Kaya maraming uri ng PEEP. Okay? Maraming uri ng PIP. Kaya pag naglagay tayo ng PIP sa pasyente, lahat ng pressure tumataas. Tumataas ang plateau, tumataas ang peak pressure, tumataas din ang mean airway pressure. Tumataas siya. Kaya halimbawa, kung wala kang PIP, ang peak, ang plateau pressure mo halimbawa ay 20 ang plateau pressure mo, ang peak pressure mo 25 pag wala kang PIP. Pag naglagay ka ng PIP, lahat yung plus 5. Halimbawa, naglagay ka ng PIP of 5, lahat yung plus 5. Kaya yung plateau pressure mo na 20, magiging 25. Yung peak pressure mo na 25, magiging 30. So, lumalapit ka na dun sa ceiling mo kasi tumataas yung pressure. Ganun siya. Pag naglagay ka ng PIP, titignan nyo, lahat yung tumataas. Ganun din ang mean airway pressure. Ang mean airway pressure. Pag naglagay ka ng PIP, parating naka-open yung lungs natin, pag nakalagay ka ng PIP, ibig sabihin nun, nako-compress yung heart kasi lahat ng baga natin positive, naiipit yung heart. Kaya titingnan natin yung hemodynamics ng pasyente. Kasama yung lung compliance, yung blood pressure, etc. Pag naglagay tayo ng PIP. Napapalo nyo ba?
Yes po.
Okay, thank you. In comparing CPAP and PIP, PIP exerts a more negative effect on the cardiac output as it raises the mean airway pressure proportionately. Yung PIP sa CPAP pareho lang naman. Kaya lang, ano sabi rito? PIP exerts a more negative effect compared to CPAP. Why? Kasi yung CPAP is spontaneously breathing. Okay? The patient inhales negatively. The patient has spontaneous breathing compared to a positive pressure breathing. Mas devastating ang effect ng PIP kasi mechanical ventilation niya compared to CPAP. Spontaneously breathing kasi siya. The effect of PIP can be detrimental to the cardiac output because PIP is the end expiratory pressure used in addition to positive pressure, whereas CPAP is the pressure that includes only positive pressure during spontaneous. So yun ang difference nilang dalawa. Okay? So makikita nyo rito, no? Yung PIP sa CPAP, pareho silang may pressure above zero. Kaya lang yung PIP, dahil mechanical ventilator nga siya, mas mataas yung pressure niya. Kasi meron kang peak inspiratory pressure, yung letter B, no? So, ang peak inspiratory pressure niya ay 40 kasi meron siyang PIP of 10. So, nag-umpisa siya ng 10 plus 30, 40 ang bilang niya. Yun. Mas mataas siya compared dun sa CPAP na spontaneously breathing. So, ang effect ng mechanical ventilator plus PIP, of course, pinakita natin kanina, decrease cardiac output. So, kung decrease yung cardiac output, decrease yung oxygen delivery. Ganon din sa blood pressure, no? Kapag decrease ang cardiac output natin, decrease din ang blood pressure. Ano pa? So, lahat naman yan decrease, no? Yung effect ng ating positive pressure ventilation. So, sa hemodynamics natin, the major hemodynamic measurement affected by positive pressure ventilation include central venous pressure and pulmonary artery pressure. Yung central venous pressure, ito ay para sa right atrium at yung pulmonary artery pressure, of course, ay sa pulmonary artery. The PCWP, or pulmonary capillary wedge pressure, is not affected to a great extent. Kasi yung PCWP ay para sa left ventricle yun. Because of the capability of the systemic venous circulation to compensate or regulate changing blood pressure and volume. So, effects of positive pressure ventilation and hemodynamics. The lung expands, but the lung becomes positive. So, increase intrathoracic pressure. The lung becomes positive pressure. As a result, decrease ang ating pulmonary blood volume. Naiipit kasi yung puso. Decrease ang venous return. Decrease ang right ventricular stroke volume. Decrease pulmonary artery pressure. Decrease filling pressure, and decrease left ventricular stroke volume. Yun ang effect niya. At dahil decrease lahat, decrease din yung dugo na pumupunta sa ating kidneys. Yan, decrease din ang ating urine output. No? Decrease. Kidney is decrease. Decrease urine output. Konti lang yung lumalabas na ihi sa pasyente. Kaya kapag ang pasyente naka-mechanical vent at mayroong PIP, titingnan natin yung kanyang urine output. So indicators for renal failure. May tinatawag tayong oliguria. Oliguria, kakunti lang yung urine niya. Less than 400 ml in 24 hours or less than 160 ml in 8 hours. Ako, delikado yon. Kapag kakunti yung urine niya, baka nagkakaroon ka ng renal failure. At kapag may renal failure, ang tinitingnan ng mga doktor ay yung BUN and creatinine. BUN means blood urea nitrogen and creatinine. Pag mataas yung BUN and creatinine, baka meron kang renal failure. At kapag meron kang renal failure, apektado din yung mga drug clearance. Yung mga gamot na dapat lumalabas sa ihi, hindi niya na ilalabas. And so on and so forth. Hepatic, meaning yung ating liver. Hepatic perfusion accounts for 15% of total cardiac output. Positive pressure ventilator alone does not alter blood flow to the liver. But when PIP is added to mechanical ventilation, the blood flow to the liver is noticeably reduced. No? Kapag meron tayong PIP na inilagay, naapektuhan din yung flow to the liver. At para malaban natin yung function ng liver, impairments of liver function is likely when the prothrombin time is more than 4 seconds, bilirubin is more than 50, albumin is less than 20. So, isa sa mga indication for liver function, yung prothrombin. Yung prothrombin, yung pagkaklat ng ating dugo. So, kapag matagal magklat yung dugo, ibig sabihin mahaba yung prothrombin time. That may be a sign of liver function. Bilirubin level is increased. Kapag naninilaw ka, ayan, mataas ang bilirubin mo, more than 50. Or, when albumin level is decreased, kapag namamanas ka, mababa ang albumin mo, they may be a sign of liver function. Next, abdominal consideration. Increases in intra-abdominal pressure are related to clinical conditions such as bowel edema or obstruction. IAP may also be increased in procedures such as pneumatic anti-shock garment and surgical repair of the abdominal wall. When these patients are placed on mechanical ventilation, conditions that are conducive to an increased IAP should be monitored to avert potential condition. So yung mga pasyente na mayroong bowel edema, obstruction, or ascites, sila yung mga pasyente na magkakaroon ng malaking problema kung meron silang mechanical ventilation. Otherwise, kung wala silang mga problem nito, okay lang naman tayo. Wala tayong problem doon. Gastrointestinal consideration. Positive pressure is associated with many organ system complications which may include the gastrointestinal tract. Kabilang dito yung esophagitis, stress-related mucosal damage, diarrhea, decreased bowel sound, and decreased residuals and constipation. So it also affects the gastrointestinal tract. May tinatawag tayong gastrointestinal tract injury because of mechanical ventilation. And of course, yung ating nutrition will be severely affected. Malnutrition in critically ill patient can create muscle fatigue, ventilatory insufficiency, and ventilatory failure. Kaya kasama din yung diet kapag nasa hospital because the doctors would like to compute the exact calorie required by our patient kasi kailangan din yung nutrition. Okay, so I think that's it. So sa ating chapter 2, para mamaya pagbalik natin, dito na tayo sa next chapter. Yun lang naman ang effect ng positive pressure, naiipit yung ating puso. Okay, so bago tayo mag-lunch, I'll be showing you one last video regarding the effect of positive pressure. Then we will have our lunch. And then pagbalik natin mamaya, chapter 3 na tayo.
Hi, my name is Alan Post, and I'm your instructor for REST 220. And today we're going to talk about Module 7, the physiological effects of mechanical ventilation. Our source for information on this is Egan's Fundamentals of Respiratory Care. Chapter 43 is the chapter you want to read for our references for this section. So what I'm going to do is I'm going to review the PowerPoint presentations with you and highlight what I think are some of the key points you want to remember from these slides. All right, so let's get started. So we've got our PowerPoint here. I'm just going to color along with me, and we're talking about Module 7, Physiological Effects of Mechanical Ventilation on the respiratory system specifically. Okay, now we've already talked about in class how our basic settings on the mechanical ventilator, we usually have a little bit higher respiratory rate and a little bit higher tidal volumes than you normally physiologically have, and that's because we've got increased amounts of dead space ventilation. All right, and that's because the ventilation goes primarily to the most compliant regions of the lungs and areas of poor perfusion. So that's just an example of one of the major physiological effects of mechanical ventilation, and we're going to review that in many of the others. Okay, so what are we going to talk about? Barotrauma, volutrauma, electrauma, biotrauma, and oxygen toxicity. Now, I know we've been referring to those in the class, but we're just going to give you a little bit more detail on those. All right. Sometimes you'll hear me refer to a ventilator-associated lung injury, and so that's what wraps up and talks about all this damage due to positive pressure ventilation on the lungs. So, barotrauma. When we have a lot of pressure inside the lungs, we can actually rupture the alveoli themselves and release gas right into the interstitial space. And that's what we're talking about here, that interstitial emphysema. Sometimes you can actually get some of it leaking out, and you can feel it around either the neck or areas outside the lung areas themselves. But often it's right in here inside the lung that it creates the biggest problems for us. And you can see that on chest x-rays. And this means that we've got areas now that the air is not moving around, and it can actually decrease the compliance of the lungs and limit gas exchange. So that's really problematic. Of course, a major problem would be a pneumothorax, where you're going to get air collecting between the lung and in that pleural space in here. We're going to have to put chest tubes in place here to keep that lung units distended. All right, this is actually in some ways easier to manage than interstitial emphysema. A pneumopericardium, where we get air collecting around the heart like this, can be very problematic and can be life-threatening very quickly, because that increased pressure around the heart can actually severely decrease cardiac output. So we have to be knowledgeable and diligent about these, but of course, how do we prevent them? That's the big question, and we'll talk about that very soon, in that we limit the plateau pressures. All right? So volutrauma. Now, the concept of this is where we put in a set volume. And in this case, I'm going to say, well, say we're putting in a regular tidal volume to a patient of 500 mils. In a normal healthy person, this would be equally distributed to all the lung units. So here we are at our basic PEEP, and as the flow goes in, I'm going to get some volume in here and some volume equally distributed between those. But now if I put in that same tidal volume, 500 mils, into a lung unit that's got variable compliance, less of that volume is going to go into these areas of poor compliance, which is often the disease, so we've got low compliance, and these with normal compliance are going to be over distended. So this would be the concept of volutrauma, this over distension of healthy units. And how do we prevent that? Often by, again, limiting the pressures in the lungs. So instead of putting in a set volume each time, we can limit the damage of volumes by just using a pressure target instead, and thus why we often use pressure control ventilation. All right. Atalic trauma is where we actually get sections that are collapsing and sticking together. All right. And I know I've mentioned this in class a couple of times. You've heard me doing my clapping of my hands, talking about the dangers of atalic trauma. All right. Here, because of the low surface tension, what happens is the alveoli will actually collapse and stick together. Now, the danger, of course, is when this pops open. The shearing forces here can be huge and actually can cause rips and tears in the alveoli themselves and can cause capillary injury. All right. So that's what we're causing. And this is that shear stress is caused when we allow the alveoli to pop in and open. Now, if we've got areas that are just just collapsed all the time, of course, we're not going to get good gas exchange there, and that's going to affect our gas distribution and our blood gases. Right? Biotrauma, this can occur when we get the body's actually reacting and damaging the lungs themselves. So we get these inflammatory mediators. This can often be associated with ARDS, for example. And this can actually damage the lung tissues themselves, causing that decrease in compliance. And of course, we're going to have increased oxygen demands, things like that going on. All right. Um, a primary mechanism for this is if you had somebody who aspirated gastric contents and they get this huge inflammatory response in the lungs, for example. So how do we manage this with a ventilator? Well, we've got to decrease the pressures, try to maximize oxygenation, and keep the patient alive long enough so that their own body can start to heal itself. All right. So what are some of the physiological effects of positive pressure ventilation? And of course, we talked about those shearing and ripping forces, and that's what you can see occurring right here in this diagram here. And we know from controlled experiments, was what this photograph here is showing us, that over distension and repeated tearing of the alveoli like this causes this change in our lung structures to this darkened and damaged areas of lungs like you're seeing in here. And that's due to over distension and this tissue shearing forces that we're seeing. All right. So what are some of the other effects that we should be aware of as respiratory therapists? Well, if we cause a lot of air to be going into the chest, sometimes with asthma patients or COPD patients, we can actually get air trapping. And this is where we haven't allowed enough time for exhalation. All right. So often if we increase the TE, we can limit these effects. All right, letting more time for exhalation. Reality is that air trapping and auto PEEP can often be beneficial to our patients because it actually increases mean airway pressures. All right. So in severe cases, we sometimes manipulate air trapping to the benefit of the patient to increase mean airway pressures. All right. It also causes a mechanical bronchodilation, allowing airflow into some of those distal units that would normally be collapsed. And of course, we're going to increase functional residual capacity. So like a lot of things we do with a mechanical ventilator, there's positive and negative effects to things like air trapping and auto PEEP. All right. The mechanical bronchodilation, when we keep PEEP in the airways in the lungs and we inflate them, this causes the airways to be open larger, so it actually decreases airway resistance. Increased functional residual capacity, I've got less area for a pneumothorax or air atelectasis to occur. All right. Well, we know that when we put people on a positive pressure ventilator, we're doing things very differently than when they're spontaneously breathing. And that can change where that ventilation is going to go and its effects and how well it's going to participate in gas exchange. All right. So perfusion goes to the gravity dependent areas, but often when we put people on a positive pressure ventilator, the ventilation does not go in the same place. So we get this increased dead space ventilation. All right. We get an increase in the VDVT. Right? Okay, well, that's fine. And we can compensate for this by increasing the patient's overall minute ventilation. All right. And we see that in our basic ventilator settings. A normal person will have a minute ventilation of about 5 liters per minute. On a mechanical ventilator, it also has to be 6.5 to maybe even 7 liters per minute. All right. And that's because of this unequal or unusual distribution of a positive pressure breath going to the, say, more to the apices or to that zone 1 than to the areas that have good perfusion. All right. So we get both an increase in dead space ventilation and an increase in shunting, because some of those areas where there is good blood flow, there's not enough ventilation, so that blood goes through without participating in gas exchange. So that's a shunt. All right. So here's another example of how that happens in um, our spontaneously breathing patient. Even though they're laying on their back, most of the ventilation and perfusion is matched quite well, because the diaphragm moves down, and of course the blood flow is going to be mostly in this region here where most of the ventilation occurring. So you're going to have a fairly normal gas exchange and dead space. When we push the air in, instead of it going to those lower regions here, its focus is to these upper regions because they have higher compliance. It's just easier. These ones are engorged, they've got blood circulating all around them. And so the ventilation tends to go to these upper apices with very poor perfusion. So the result of that, we get VQ mismatching. All right, so the infamous VQ mismatch. That means we need more minute ventilation to get the same PaCO2. Okay, so physiological effects, positive pressure ventilation. You're hearing me say that a lot. Pulmonary vascular resistance. This is tough to get your head around because in some instances it's decreased, and in some instances it's increased. All right, so we can get a decrease in pulmonary vascular resistance because we actually have higher PaO2s and lower CO2, and that will improve pulmonary perfusion. We may get an increase in pulmonary vascular resistance when we have actual compression of the alveolar capillary membrane and the capillary around the alveoli with overdistension of the alveoli. So the alveoli is pushing out here, and it's increasing pulmonary vascular resistance, so very little blood gets through here. Now, this is important clinically because when this starts to occur, increasing PEEP and pressure in the lungs is going to be detrimental. All right. So instead of actually improving oxygenation or improving blood gases, we'll have the opposite effect because there's just simply no perfusion occurring in these areas. And you see that sometimes in neonatal patients when you actually have to back off on the ventilator pressures. Okay, how do we minimize these effects? This is the critical element for us as respiratory therapists. First thing we're going to do, we're not going to put in very big volumes. We're going to use low volume targets, 6 to 10 mils per kilogram. And we did that in our case study in class the other day. We're also may consider permissive hypercapnia. So instead of having that PaCO2 goal of 40, maybe we'll allow that to rise and just keep an eye on this on the pH. So we can have a patient whose CO2 is 80 or even 100, but as long as they're not too acidotic, we'll be okay with that. So by limiting the amount of minute ventilation, we can limit the amount of damage due to volume/barotrauma. All right. Make sure the endotracheal tube placement is correct. We're going to do that all the time. Avoid these sigh breaths, those little bit larger type breaths. And we do that with specific type modes like airway pressure release ventilation. Okay. And we can use PEEP appropriately, and that's a difficult thing to do. We're not sure what some of the PEEP levels we're supposed to be using, but we know that if we can prevent that atelectasis and that shearing, that might be a good thing for our patients. So we always have a little bit PEEP on board, and if they're really sick, we might go up to 8 or even 12 centimeters of PEEP, depending on their disease process. All right. We're going to monitor for auto PEEP so that we're aware of when we're potentially over distending the alveoli. And we're going to minimize de-recruitment with our appropriate use of PEEP. You notice the word PEEP coming up here a lot. So we spend a lot of time thinking about what the appropriate PEEP level is, but it's very hard to do. And we're going to talk about other strategies next year with the ventilator and looking at our waveforms to optimize PEEP. All right. So the ventilator doesn't just affect the lungs. Now, as respiratory therapists, that's a big shock. We're saying, well, what else is there? But in fact, there are significant cardiovascular effects. It does affect cerebral perfusion. There's all major systems, such as the renal and liver system, even the gastrointestinal system. We have some psychological effects on our patients. Just being on a mechanical ventilator, I mean, let's face it, you're not on a mechanical ventilator unless you're in a life-threatening situation. We've got changes in metabolism and, of course, being on a mechanical ventilator can cause muscle atrophy. So let's take a quick look at some of these. Okay. Now, with a normal spontaneous breath, we create negative intrathoracic pressures. So when we do that, we actually increase venous return. So we take a big breath in, and when we breathe like that, we enhance venous return into the thoracic cavity, and that promotes filling of the right side of the heart. So the right ventricle receives a good filling and the preloads improved. So that can actually increase cardiac function even when we spontaneously breathe. All right, but it's reversed when we have positive pressure breaths. So in a spontaneous breath, we enhance venous return, helping fill that right side of the heart and improving cardiac function on a spontaneous breath. Okay, but in a positive pressure breath, this is reversed and limited. All right, so when we force air into the lungs, we decrease right ventricular preload, the exact opposite, and this can actually decrease cardiac output. So it's a subtle but an important effect, and this can be very important for a patient who's already got limited circulating volumes and poor cardiac output. This effect on the thoracic system should not be minimized. An example of how I can get you to apply this thought process to this is if you put a pulse oximeter on your finger and you take some long, prolonged, deep inspirations through pursed lips, when you create a lot of negative intrathoracic pressure, you'll notice that your heart rate actually decreases. Most healthy people by about 10 or 15%. And that's an example of this thoracic pump in operation. Yeah, try that in the lab sometime. All right. So unlike before, with positive pressure ventilation, we're pushing and creating back pressure against that filling during inspiration. So inspiration now is a positive pressure element, forcing blood out of the upper thoracic cavity instead of drawing it into the blood, into there. So we limit the preload on the right side, and that decreases cardiac output. Here's another way to view this. All right, so you can see here we're enhanced venous return with spontaneous breathing. So we're improving that. All right, because we've got this negative intrathoracic pressure, so we enhance that venous return, enhancing right atrial and right ventricular output. Okay, with a positive pressure breath now, we actually push against these vessels, and that decreases our venous return. So we're actually pushing some of the blood out of the thoracic cavity, decreasing that, limiting right atrial preload, limiting right ventricular function. So that's a major effect on the cardiovascular system. All right, there's nothing we can do about that. All right, so whenever we have transmission positive pressure, usually with the PEEP and those larger mean airway pressures, we're going to decrease cardiac output. So the amount of PEEP and your positive pressure ventilation and your mean airway pressures are a major effect on cardiac output. Now, of course, if you've got a disease process like ARDS, where the lungs are very stiff, the amount of transmission of that pressure to the thoracic cavity is diminished. So if you have an emphysematous patient, for example, that's going to increase this effect. All right, that's our COPD patient. Pressure transmission is very effective, so these patients are going to have dramatically decreased cardiac output, where these ones, it'll be a less effect. Thoracic compliance also plays a part of this, because if you're pushing against a stiff abdomen, or you've got a stiff chest wall, the amount of pressure that's going to be built up in the thoracic cavity is greater. All right. So the effects of positive pressure ventilation on the cardiac system impedes cardiac output, decreases blood pressure. All right. So the patients that are most worried about that, chemically unstable patients, MIs, for example, patients with low circulating volume. So if they've got shock, all right, if they're hypotensive, this is going to be a much more important effect. Okay. One of the other things that can happen is that we can have a cause cause a change in intracranial cerebral perfusion? Well, that seems like a hard thing to get your head around, all right? That changes in cerebral perfusion pressure. But we know there's two mechanisms at play here. One is that if we hyperventilate a patient and lower their CO2s, that decreases um, blood flow to the brain because this causes vasoconstriction. So that's a mechanical effect that causes that. The second one is when we have increased intrathoracic pressures, we decrease the blood returning from the brain, and that can reduce the overall pressure gradient, decreasing cerebral perfusion. Well, that's cool, but what does it mean for patients? Well, we're just going to limit both of these effects. We're going to limit hyperventilation, and we're going to limit the amount of pressure if we can, in the thoracic cavity. Sometimes there's just nothing we can do about it. The patient will just have to survive. So surprisingly enough, the renal system is also affected by positive pressure ventilation. Now, I don't want you to memorize all these different responses here, okay? I want you to be aware that if we have a patient who's hypoxemic, a patient with high CO2s, we're going to damage and cause decreased kidney function, all right? How do we limit this? By keeping the PaO2s in the normal range, keeping the CO2s in the normal range, and not allowing large pH imbalance, all right? So that's how we limit the physiological effects of positive pressure ventilation on our kidneys. I don't want you to try to remember all these ADH and AMPH releases. All right. How do we monitor kidney function? Ask the nurse, what's your kidney function? How much urine output are we having? Those kinds of factors can be important. All right. Just for an FYI, liver function can be impaired. We've got increased positive pressure in the thoracic cavity, and that's going to directly affect hepatic blood flow.
Cannot name this
Anything
as
that
Caesar.
impedes
It's Caesars
liver blood flow
because
is going
it's
to
steak.
decrease its
Okay?
effectiveness. All right. The gastrointestinal system is a kind of surprise to us.
When
We know
talking
that
in
there's some
English,
strange
you need
reasons
to speak
that
in English as
for
well.
patients on
So that
positive pressure ventilation, they tend to get more gastric bleeds, they get ulcers. Um, there's a lot more
practice.
requirement for
Because you know, in
antacids,
Hanroots
and we
around,
also are
we're going to
concerned
be
about that
speaking
gas
English
called
there so that
NOx
people will look at us, okay?
causing ventilator associated pneumonia. All right. So how can we prevent these? Well, if we
Dasod mo
can,
ko
we're
maglimot na
trying to
tal.
intubate
Bago din ang
patients. We're
kamuan.
trying not to give them ventilation longer than they need it. And sometimes being non-invasive can also be helpful. All right. When we put a patient on a positive pressure ventilation, we do that often because we're trying to decrease CO2s.
Gunting ini mga
What we're trying to do is to allow the body to
Eh,
heal itself. To decrease O2 consumption, to increase CO2 production. And this can be very important because a lot of, or there's many conditions that cause a hypermetabolism, and such as with major surgeries where the patient's need for oxygen and CO2 production are greatly increased. So in these situations, reducing the demands on the body can actually reduce how much oxygen we need to deliver to the patient. How do we combat these? Well, make sure they're they've got good nutrition, and we keep your gases in the normal range. When we keep a patient on a positive pressure ventilator for a long period of time, we're going to get muscle atrophy. This used to be a big concern for us, and we thought about this weaning process.
Nakikinig
But we
ka?
know now that many patients can actually
Nakikinig
bounce
ka?
back pretty quickly, and we need to get them off the ventilator as quickly as possible.
Hello?
So some patients are going
Hindi
to
mo ako
require
marinig.
mechanical ventilation for an extended period of time, and we
Hello?
may have to have a kind of a weaning process to get them
Hindi na
used
ako
to breathing on their
nakikinig,
own again.
Yahuwah.
But for many of our patients,
Akala ko
as soon as their
early
disease process
lunch.
resolves, we can get them off the
Hindi siya
ventilator.
early
So be
lunch.
aggressive in trying to
Akala
get
ko
them
early
off the
yung
ventilator.
lunch natin.
Being on a ventilator is psychologically stressful, not just for the family, but also for the
Ang
patient.
hiya
As you can
talaga
imagine,
kahit
they're
man lang
relying
mga
on this
ilang
machine to keep
meter.
them alive. So it can be very difficult to sleep in this noisy environment with that tube in your throat and your chest being filled in by a
Ano yun?
mechanical device. We know that causes a lot of anxiety and
Ano
frustration,
yun sabi mo?
that they become ventilator dependent. They become depressed often. And this you have to watch for because when they start getting those kinds of symptoms, they believe they need the mechanical ventilator to survive.
Hindi
So when
ko
you're
alam. Sinabi
talking
niyo ba
about,
yun?
oh, we're going to get that tube out and we're going to extubate you today,
Hindi ako
that can actually
nakikinig.
increase them and their feelings of helplessness, their need to be
Kala ko
suctioned.
sinabi niyo.
They're actually in fear of you taking the ventilator away. So how are you going to deal with that? You're going
Ano
to
na
be
ginagawa
positive with
mo?
your patient. You're going to be clear about what you're trying to do with them and why this is beneficial with
Hindi
them.
ka na
You're going to make
natulog.
sure that you talk to them as a human being,
natulog.
even if they can't respond to you. All right. And when you're suctioning them, you're going to
Di
make
pa
a little
ako
bit of eye
nag-ano.
contact. You're going to be talk them through it, even if they seem semi-conscious. Because a lot of times they're hiding out inside the back of their head.
Bakit
They're not
wala ka
really
dyan?
unconscious. All right. So I've given you a
Wala
quick
ka dyan.
review.
Ari, akin lang sila na kahit ayaw ako sila. Ayaw na. Ayaw na tulungan. Yung sala ko nakatawaran ko.
Okay, so we're done with chapter 1 and 2. So mamaya pagbalik natin, more interesting topics
Sino
about
mo?
mechanical
Lagi yan
vent.
sa
So
ganyan.
mag-lunch muna tayo ha. Tuloy natin mamaya 1 o'clock.
Alam mo yung parang ano.
Yes, sir.
Thank you, sir.
Thank you, sir.
Kailan
Sige,
sir?
sir.
Thank you po.
Thank you, sir.
Thank you, sir.
Welcome.
Thank you, sir.